Right. So going back to the topic of aortoiliac occlusive disease from the previous session, and it is very common. It affects over 7 million people in the US, and it actually is more common than abdominal aortic aneurysms. And more importantly, it does affect people in their productive age as well. Not all of these patients are elderly. There are multiple options for treatment of aortoiliac occlusive disease. Over the years, we've gone through aortobifemoral bypasses, aortoiliac endarterectomy, and kissing stents using both uncovered and covered stents, and aortic unibody EVARs, as well as CRAB. Back to TAS2, and the initial recommendation for type C and D lesions for aortoiliac occlusive disease was an open surgery approach first. And even all the way back in 2017 with the ESVS guidelines at that stage, that if the occlusion comprises the aorta up to the renal arteries and iliac arteries, an aortobifemoral bypass is indicated in fit patients. So looking at outcomes from Chu et al., where they compared different open procedures, so aortobifemoral bypasses, iliobifemoral bypasses, and aortoiliac endarterectomies, there was no difference between the three approaches, the three open approaches, when it came to overall primary patency, albeit with less operative mortality and morbidity in the aortoiliac endarterectomy group. But for anyone who's done an aortoiliac endarterectomy and you felt the plaque and the calcification there, you start to wonder, really, are we doing the right thing if we're using, or from what became our kissing stents, using uncovered stents? Mainly because that calcium and that extensive calcification leads to cases like these of extravasation when you're using uncovered stents. So the COBUS trial, as has already been mentioned by Martin Schroeder in the earlier session, has kind of looked at covered stents and the advantages of covered stents over uncovered stents in the iliac segment. And mainly for TAS-B lesions, there isn't really much of a difference when it comes to covered and bare metal stents. However, once they looked at the subgroup analysis of the TAS-C and D lesions, the covered stent placement resulted in higher patency rates. And there were slightly less favorable outcomes with the DISCOVER trial results. So our most up-to-date ESVS guidelines have actually now started to recommend covered stent placement could be considered over bare metal stents in TAS-C and D lesions. So we now can at least be a little bit more comfortable when we've got tight stenoses like these that would require an atherectomy to go up, and then cover it with our Bentley stents in this particular case. I'm not sure why the completion angio following the stenting isn't working. Sorry. But again, similar to what Martin Schroeder mentioned earlier on, we still have the issue, are kissing stents the right approach? And mainly because of the geometry and the radial mismatch that happens from kissing stents. So your group A is the uncovered kissing stents, group B is covered kissing stents, C is our traditional CRAB with the two iliac limbs only shifted up about just under a centimetre within the aorta, and then your group D is where those limbs are shifted a little bit further. And the kissing stents seem to be associated with non-ideal geometry at the aortic bifurcation that can lead to thrombosis and formation of intimal hyperplasia. And the mean mismatch was less in the group C, which had the shortest less than 1 centimeter advancement within the aortic component. And that led us to kind of look at things like the aortic unibody grafts, like the AFX graft, because the configuration is very similar to that of the Group C there, with less radial mismatch. So you could end up still with cases like these with full occlusion, and if you manage to snare your wire across to the other side, you should still be able to get your aortic unibody AFX in cases like these. The reports by Maldonado et al. Showed that the 1 and 2 year primary patency rate was about 90%, with a freedom from secondary intervention of 92%, and those results were echoed by Van Heeren et al. As well. But there are certain issues there that if you are going to be putting in an aortic unibody endograft, that you try and remember to use the shortest body that would work for you without covering as many collaterals. And at the same time, there's less radial force in those devices than you would get from balloon expandable devices. So you either post-dilate or look at a proper CRAB rather than using an AFX. Looking at the CRAB, the results from Carl Zabrit's group, their initial results showed a patency rate of 87% for CRAB, with using a low-profile delivery system with low risk of rupture. And then looking at the multi-center observational UK study, where the results were collated and published by the group in Thomas's. There were 116 patients included in the study, and the mortality, the all-cause mortality, was about 3.5% in CRAB. Aortic stent occlusion was about 1.7%. Iliac stent occlusion, 2.5%, very minimal surgical reintervention, but about 10% endovascular reintervention of target lesions, with negligible major amputation rates. The 12 months freedom from TLR was 94%, with an overall freedom from TLR after 3 years was about 84%. There were similar results from the Polish multicenter observational study with just slightly larger number. And again, no major amputations, and the endovascular TLR was 8.3% procedures, and the freedom from TLR at 1 year, 94%, at 2 years, 91%. Looking at the systematic review published by the group from Thomas's as well, 9,000 plus patients, but it looked at all aspects of management of aortic occlusive disease, not just CRABs. There were 66 articles included in this meta-analysis. Only 4 of them were RCTs. And out of those 4, one was the COBEST trial, which obviously didn't look at CRAB per se, and the other 3 looked at different open aortobifem grafts. So no RCTs were included in this that were related to CRAB. Obviously, the number of CRAB cases out of those 9,000 were only 240, but still, despite that, there was much less 30-day morbidity and mortality compared to open bypass surgery. And more importantly, the 3-year secondary patency was equivalent to open bypass surgery. And again, now you might notice an ever so slight change in the wording of the newer guidelines compared to the 2017 ones, where now when we're recommending open surgery, we're looking at people not just that are fit, but people who are considered low risk with long life expectancy, if you are going to consider open repair. And finally, there's a more recent systematic review only looking at, that was just published last year, only looking at CRAB, and the pooled secondary patency rates at 36 months were 97% as well. So very quickly, before I finish, in Galway, we have used nearly all of these approaches, but I'm only going to concentrate on comparing the CRAB versus aortobifem. So 53 patients done with CRAB and 67 with aortobifem bypasses. No differences in baseline, and all of them were, or the majority were between Rutherford 4 and 3 on presentation, and with TAS-D lesions. And there was no difference in technical success, 30-day mortality, or 3-year mortality or major amputation rates, nor was there any difference in the freedom from TLR at 36 months. So in conclusion, ladies and gentlemen, most patterns of aortoiliac occlusive disease may be successfully treated using an endovascular approach. For complex lesion, preferable to use covered stents, and CRAB as an approach and a geometry, it is geometrically sound and has the potential to achieve similar long-term patency as open repair and does seem to be here to stay. However, we still do not have an RCT on comparing CRAB properly to other approaches. Thank you.